Good afternoon, and thanks for being here during your lunch break. My name is Angela Hagaman, and I work with the ETSU Center for Prescription Drug Abuse Prevention and Treatment. This is the fourth module, the final module of a series. How many of you attended the other modules? Has anyone attended all four? Great. All right. So if there's any questions that hi, welcome. Any questions that you have or anything that you'd like for me to follow up on from previous modules, we can do that at the end. I'll hang around at the end if there are any questions that need to be answered. So my role, prior to coming to the center, I was a public health professional. I was a prevention specialist in Western North Carolina. That was my role there, and I also have a counseling license in North Carolina, so I've worked with folks in treatment, both in Tennessee and in North Carolina. So my goal today is to talk a little bit about the continuum of disease and ways to prevent substance use or address substance use along the disease continuum, both in the clinical setting and in the community. So I'll talk a little bit about what we're doing in the center, what best practice says to do along that continuum, and then have some opportunity for conversation if you want about ways that you can implement things in primary care. So I won't quiz you, but there was some reading, some pre-reading. Did you all take the naloxone training prior to? Okay, so a few of you took that. Are there any questions about that training or the use of naloxone or co-dispensing of that in the clinical setting? Okay, we're good with that. All right. And so the reading that I have was the Institute of Medicine's version of the continuum of disease and preventative interventions along that continuum is similar to ours, but they use terms like universal, selective, and indicated, and we use a little bit different terminology, primary, secondary, and tertiary prevention. So you'll notice some overlap there. And then there was also SAMHSA's guidance. Welcome, everyone. Feel free to go get lunch if you haven't already. My name is Angie, and we're talking sort of about the continuum of disease and preventative interventions along the continuum. And then the other reading was from SAMHSA, ways to move beyond just ESPERT and referral to treatment and integrate some preventive techniques in the clinical setting. So that was the other reading. So we'll go ahead and jump right into the slides. So I know that Rob Pack covered a lot about the epidemiology of this disease and the way that it looks in our region. So essentially, most folks in America, this is a data from 2015, do not misuse their psychotherapeutic medications, so that's good news. But 18.9 million people do, and the most frequently abused substance are pain relievers, followed by tranquilizers, stimulants, and sedatives. We look at first-year initiates by age group and who initiated prescription drug use in the previous year prior to this survey. We see that young people are overwhelmingly the highest rate of initiates. Their brain is sort of at that experimental level, and we see that pain relievers are the most frequently first misabused or abused substance. We also know that hepatitis C and the potential for an HIV outbreak is very high. We have 41 of our 95 counties are in the top 5% of the nation for hepatitis C and the potential for an HIV outbreak directly related to injecting drug use in the opioid epidemic. I will have a quick segue to say that our center just created, this is one thing that we do sort of as public health professionals. We had the results, we added some questions to the Tennessee poll, which is a public opinion poll that happens every year. We asked folks what they know about this. Do you know or do you believe that there's a potential risk for hepatitis C or an HIV outbreak related to the opioid epidemic? And as you can see by this bar graph, I'll leave a copy and can email it to you as well. 67% said that they do not believe that there's a concern for an HIV outbreak, and 63% are not concerned about a hepatitis C outbreak. So we see what the CDC tells us and what our local folks in Tennessee know. Then we ask them if they would be supportive of a syringe service program if it prevents hepatitis C. So what would you guess that Tennesseans said about that? Would they okay, so at what rate? Like guess a number. How many, what percent? 80% say no. Okay. Surprisingly, 74% said they would support syringe service programs if they prevented HIV and hepatitis C. So we put this in the box of every North Carolina legislator, Senate and House, and their staff aides so that they could have this data, because we thought that people would be against it. So I did want to put that out there. So you've heard about neonatal abstinence syndrome. You know about the rates. I know that Rob shared that with you, but this continues to be a problem that we would want to intervene on. And this is, we know that in Sullivan County, I think the rate's more like 55%, but it's one of the highest rates in the nation. And we have a very high rate here in Northeast Tennessee at 48. It's hanging about 48 for every 1,000 live births. So we know these are the problems. So I won't spend a lot of time there, but we look at the difference between East Tennessee and West Tennessee. Shelby has the rate of 1.7 births per 1,000, and Sullivan has 55. So we see the disparity and the difference across our state. So the working group, our center started in 2012 with a small group of folks talking about this problem. And since then, we now have 240 members that attend, and you're all welcome. It's the second Tuesday of every month. And we talk about this problem from a variety of different angles. We have different sectors represented. This is when we only had about 100 folks. So best practice says that the best way to address epidemics such as this one, or any, I would say, chronic health problem, is to engage all of our different partners, both from the medical professions and in the community, and this is what we looked like at about 100 members. So our center has 4 cores. We have the administrative core, which employs, I'm currently the only full-time employee in the center, and then we have other principal investigators. But we do patient care in the form of methadone treatment currently at Overmountain Recovery, and we're looking to use other medication-assisted treatments and treatment modalities there. That's a partnership with Ballad Health. We do education and outreach to the community across the continuum of disease, everything from providing funding for NAS research over at Niswonger to doing prevention in the workforce. And we also do ongoing research. In the past 5 years, we've submitted 24 proposals, 9 of which have been funded. So we're doing ongoing research about this problem, primarily around communication between healthcare professionals. So we know it's a complex problem, and your reading talked about the Institute of Medicine's approach, the sort of idea that across the continuum there are different levels of intervention. We look at it much like them, and I'm going to unpack this because this is a very busy graphic that we use consistently, and I hope that we can redesign it. What I will say before I start unpacking it is this is the individual's potential movement across this continuum. This model does not take into effect the community within which a person lives. So we know that, have you heard of the concept of diseases of despair? So the Appalachian Regional Commission, we know that in Appalachia, folks are 37% more likely to die from alcoholism, substance use, or mental health related to suicide. So we know that there's a huge disparity, higher rates of mortality within the region. So even though we're going to talk about this, we have to take into consideration communities and why are things different in certain communities. So it might be, I'm beginning to study a lot about communities that have been impacted by coal, or they had a major industry and the industry left, and the sense of hopelessness and helplessness that happens. And those communities are far more affected by chronic disease. And so looking at those things, we can't just think of an individual, we have to think of the context within which they live. So if we're thinking about this continuum, it starts at non-use, and you may remember that most folks actually stay right over here. They're not misusing their prescription drugs. And we also know as they move across this continuum to the worst potential consequence, which is death related to addiction, it's more difficult to turn them back. So there's that first period of initiation. That's where we would institute universal or primary prevention. And then the pink band is where the danger zone is. We know that as people move along that, they become dependent, and then at some point they may trigger addiction, and different folks trigger addiction at different rates. Some people can misuse prescription drugs for a longer period of time before they experience full criteria for substance use disorder, that loss of control. There are different levels of prevention, primary, secondary, and tertiary, and this aligns with the concept from the IOM of universal, selected, and indicated. So to unpack this a little bit more, at the beginning, in order to prevent non-use, one of the things that we can do is train health professionals, and that's what we're doing right here. So we're already doing something for primary prevention. We also do prescribing practices, and so you know that I think it's every 2 years you have to do 2 hours of training specific to prescribing practices, and the dissemination and implementation of prevention programs. So one thing that our center is doing, not only this recurring training program, but we also host a Tough Pill to Swallow. Has anyone attended this? Okay, Great, so that's once per year. I think August 17th might be the date. It's usually on Saturdays. We provide the 2-hour training that's required for prescribing practices, and we also pack in a lot of other information about what's happening in this region related to primary prevention. The dissemination and implementation of prevention programs across the continuum. These are some things that our center is doing locally. There are a variety of ways you can do this wherever you end up working. So drug prevention coalitions, it's recommended that health professionals participate in local anti-drug coalitions, and they do sort of the environmental health, the population health. They make sure that policies and practices are supportive of prevention and treatment efforts. And we noticed that Carter County, while they had very high rates of substance use, they did not have an anti-drug coalition, and they were one of the only counties that didn't. So we worked with them for about 2 years. We now have them funded, and they have a very active coalition that's being recognized at the state level for some of their work. Another thing that we did was we had city and county mayors from Northeast Tennessee in 2013 said, we know there's a problem. Please come speak to us at our annual conference and tell us what to do. We don't really need to know the data because that's not that helpful. We already know the problem. Tell us what we should do. And of the 7 interventions that we recommended, they were very interested in the workforce. They're really struggling with their local economy because of the reputation around substance use. We have industries that don't want to move to the area because they feel that we don't have a viable workforce and that people can't pass a drug test. So we began working with Mayor Eldridge in Washington County to create a 2-year plan to institute team awareness, which is an evidence-based prevention program in the workforce. Washington County adopted it, A.O. Smith Water Heaters, and a few other local businesses, and we've hosted a variety of information sessions. The design is to intervene early, to notice when your coworkers or people that you supervise are struggling. Maybe they're beginning to be absent from work or they're stressed out. I see you looking at each other, so you know when you're feeling stressed out. And sort of decreasing the stigma associated with help-seeking behaviors. So I don't know what your coworkers, what your colleagues feel about it, but if one of you notices the other one is struggling, we tend to, especially in Appalachia, it's your business. I'm not going to bother you. I'm not going to intervene. But what's recommended is that we begin to talk about this with one another and get help early before we move along that continuum of disease. So moving along to secondary prevention, PDMPs. So you're all very familiar with Tennessee calls it the CSMD, our prescription drug and monitoring program, and we know that in the first couple of years it decreased doctor shopping by about 33%. And then SBIRT. So you've already become very familiar with SBIRT. I think this actually was a clinic that was part of a pilot study, so you're very familiar with that. We know that in Tennessee and at ETSU, I don't know how commonly SBIRT is used, but we do know that the ACA was supposed to make sure that that was at no cost to the patient, could be provided and billable. I think in some areas that's true, in some areas that it's not. We also know that the controlled substance monitoring database does not only decrease doctor shopping, it also, if we're looking at the results from, I think this is 2016, strongly agree and somewhat agree are purple and blue. So it looks like folks, when they view the CSMD, change their treatment plan for patients. So it's also useful in that. And these are areas to look for intervention red flags, a tool to help us initiate that conversation with our patients. And then dispensers said that they also were likely to not fill a prescription when looking at the CSMD. So hopefully that also results in a conversation. So moving further along to tertiary prevention, or this is more indicated when we know that someone has a diagnosis of substance use disorder, they're really having very obvious problems along the continuum of a disease. We would use abstinence-based or medication-assisted treatment and or neonatal abstinence syndrome. We know that second pregnancies are a problem, and so we'd want to intervene there. So our medication-assisted treatment program at Overmountain Recovery is providing methadone, which is a service that we did not have in this region. We also know that there's a lot of tension between different types of treatment. The idea, we all like to think that the abstinence method is the best, right? So if someone can quit cold turkey and they don't need medication, we have this idea that medication is a crutch, especially for this disease. Unlike other diseases, we feel comfortable giving folks medication for other chronic diseases like diabetes, heart disease. We're not uncomfortable with that, and we don't think people should end their medication. But for this particular disease, there's a lot of stigma around this. And so we also know that there are providers that are not using medication-assisted treatment. They're using medication only and not providing adequate wraparound services. So I really think that they're doing a good job out there at Overmountain Recovery and providing the full scope of treatment that's necessary to get someone better. And again, like I mentioned a little bit earlier, neonatal abstinence syndrome, there aren't a lot of longitudinal studies about this, and we know that our NAS research group over at Niswonger, chaired by Beth Bailey, and are any of you a part of this group, this research group? Okay, Beth Bailey and Dr. Wood. We're looking at how to begin to collect data because we have such high rates of NAS. How were we doing that? We didn't have any external funding. So we worked with, I would say we courted the Johnson City Junior League because it's not sort of like your scientific NIH proposal. You have to develop a relationship and convince them that supporting research on this topic would help babies, more so than just sending volunteers to hold the babies. We wanted long-term studies. So we were able to get a $20,000 donation, and they're keeping that up for about 5 years to support the development of a database that has now drawn down 20,000 live births in the Ballot Health System and is pulling out medical record reviews for the 350. So far, we have a study for 350 records of mothers who delivered babies that were diagnosed with NAS, and looking at all of the patterns that might be involved there and what treatment was used for the infants. And we're beginning to compare that with Mission Hospital and some other hospitals and continue to seek extramural funding. We also know that NAS prevention is very important. We don't have enough workers to address this problem, but we do have at least one full-time person in Sullivan County, a nurse named Ashley Herod, and she's out there doing all of these classes. She goes into prisons, she goes into treatment facilities, anywhere that she can go to let mothers know about how to access long-acting reversible contraception, and also referring them to parenting classes or anything that they need. There's also a Step Ahead Foundation, which is a nonprofit foundation which is doing a lot of the same work. I think Lee Johnson is a part of that. Many of you probably know her. So again, it's a complicated problem. There are many effective tools. I will say that everything that we do along this continuum is based in evidence, and we have a compendium of about 50 pages of different interventions that can be placed along this continuum. If you're interested in that, we can send that to you. So there's an extensive literature review that supports each of these interventions in those boxes. So let's see, I was actually at the far right end. So overdose outreach. Now naloxone training is ubiquitous. It's everywhere. You can get training. Welcome. But when we started 3 or 4 years ago, when Tennessee first said you can ask for a prescription and anyone can get a prescription for naloxone, go to the pharmacy and have it filled. So we were out in the community actively telling people, ask your doctor, get a prescription. And then people were coming back to us and saying, it's not in stock at the pharmacy. My doctor doesn't know how to write this prescription. And so that was just 3 or 4 years ago. So we had to back up, stop training lay people to ask for this, and start talking to pharmacists and medical providers about how to write the script, what modality, what was available. Was there intramuscular, intranasal? The Narcan one wasn't even out 3 or 4 years ago. It wasn't easily accessible or affordable. So that's changed a lot, but we did a survey in Carter County of pharmacists to ask who had it in stock, who was willing to order it, who had dispensed it, and it was pretty interesting that very few pharmacies had it in stock. They were willing to order it, but they had very little request for it. So the landscape has changed a lot. We worked with Sarah Melton to create the Volunteer to Save a Life program and the Tennessee Department of Health. I kind of feel like they stole our idea, and this is recorded, but just kidding. They call it Save a Life, and now they're doing the very same thing across the state of Tennessee. But the training that we provided to them has trained over 33,000 people in Tennessee and Southwest Virginia. So again, it is a complicated problem. There are many effective tools. We often have to tell our policymakers the ROI. What's our return on investment for these things? It doesn't click through them. I must not have embedded it. But you get more bang for your buck the earlier you intervene. So you get about $18 for every dollar invested in health professions training or universal prevention programs. And as you move down the line, I think, for example, with our naloxone, you tend to disseminate about 224 kits for every save, one study shows. So it takes more the further folks move across this continuum. So stigma. I want to be sure that we cover stigma and the impact of stigma on folks seeking treatment. So when we think of stigma, we think of it very broadly, but there are a lot of research to show the different types of stigma. So not only is there self-stigma and shame that prevents people from getting treatment, there's also stigma by association. There's public stigma, this perception that folks with substance use disorder might look a certain way, act a certain way, and we might not want to hang out with them. And then structural stigma, I think from our healthcare system, from our behavioral healthcare system, from our other institutions like criminal justice. So we still have this stigma with this particular disease. There are there's a lot of evidence for effective interventions across the different levels of the ecological system. There are promising approaches that target members of stigmatized and non-stigmatized groups so that we can reach out across these different areas and address stigma. There's widespread public stigma that the belief that individuals with mental illness are dangerous, especially folks with drug dependence disorder. They're one of the most consistently stigmatized. They have beliefs of shame, blame, incompetency, and the need to punish. I still hear folks saying that you need to be punished, they need to go to jail for a little while before they get better. We still hear that very frequently. This was a study that talks about public attitudes, and there's more stigma for folks with drug addiction than those with mental illness. So the first question would be something like, would you want someone with a mental illness, that's the green bar, or drug addiction to marry into your family? So we see that most people are more open to having someone with a mental illness marry into their family than someone with drug dependence. Would you be likely to work closely on the job? Would you prefer to work with someone who has a mental illness or someone who has drug addiction? You can see there's a huge gap, a huge difference there. Would you be willing to deny employment to someone with a drug addiction or a mental illness? So folks are more likely to deny employment or housing to those folks. So we can see that there's a lot of difference here. There's also a lot of stigma related to medication-assisted treatment. There's stigma among community members, drug treatment, and other professionals and drug users. So have you experienced this at all? Okay. So we are regularly doing forums about this topic, and we just did one at the Johnson City Public Library. Inside Alliance hosted it, and they're still tweeting about it right now. So we talked about buprenorphine, methadone. We talked about the difference in the different treatment modalities and their outcomes, and we always get the question, is it trading one drug for another drug? Isn't this a choice that people could stop doing? So I'm always surprised that we're still having to answer these questions, but it is a part of our work as public health professionals, and I think a part of your work. So we still have a lot of, hi, welcome, contention among, not just among the public, not just among health professionals, but between the different groups. So we have folks from the abstinence-based NA groups that don't allow folks who are on MAT to attend their meetings. So we have a lot of sort of contention among those groups, unfortunately, although I think it is becoming better. We also have the misconception that low doses over short periods of time are the best way to use medication-assisted treatment, but that's actually associated with high rates of relapse and more illicit drug use. So that concept that you should wean people off as fast as you can is actually not indicated. So we know that there is clear effectiveness for methadone. This one particularly is about methadone. So this is a meta-analysis of all the different high-quality studies, and it clearly shows that methadone maintenance treatment has a positive impact on retention in treatment and illicit opioid use. It's a little less clear, but definitely suggests that it has a positive impact on mortality, illicit drug use, drug-related HIV risk behaviors, which we know is very important in this area, and criminal activity. And it also suggests that it has some impact on sex-related HIV risk behaviors. So similarly for buprenorphine treatment, it increases retention in treatment and illicit use, which is keeping people alive, especially with the resurgence, or not resurgence, but the fentanyl that's out there now. We really do need to retain people in treatment, more important, I think, than ever before. And then again, there's mixed evidence for its impact on non-opioid illicit drug use. So we know that stigma is a barrier to evidence-based care for receiving mental health services. So self-reported measures of why folks didn't receive mental health services. Cost was one of the biggest barriers, and we know that's still a problem. We have this concept that there should be parity between behavioral health care and other health care, but that isn't quite happening yet. We also know that people have a low perceived need for accessing behavioral health care services. And that's one thing that I was talking about with workplace interventions, getting folks to realize that getting care for our mental health needs actually is impacting our physical health as well, and they're all sort of combined. But also stigma was a huge barrier to folks accessing care. And there are structural barriers to accessing mental health care, and then at a smaller level, folks think that these services actually don't help. So there are examples of promising anti-stigma strategies. So we have those different levels. The self-stigma can be addressed through therapeutic interventions, and there are evidence-based ways to do that, and through peer support. So there's a lot of movement on using folks who are in long-term recovery to work with folks who are new to their recovery process. That helps a lot with that idea of self-stigma and shame and blame. Public stigma, there are education campaigns, and I know the United Way of Greater Kingsport is looking at funding a large-scale regional campaign that shares stories of recovery from folks not just in abstinence-based recovery, but those that have used MAT to sort of challenge some of the stigma locally. Welcome. And then having more contact with persons with mental illness. So this idea that we're separating ourselves from folks with substance abuse and mental illness is not helpful. Have any of you heard of the opposite of addiction is connection, and seen that little video? Has anyone seen that? I think it's Johann Hari. It sort of conceptualizes his work and the idea that isolation and lack of connection is leading folks to addiction. And so although stigma separates folks, the more that we can have contact with people and engage with people, the more likely they are to access treatment and get better. And then motivational interviewing and some of those concepts are used in SBIRT. And then policy change, making sure that we have adequate access to mental health and behavioral health care. And then contact-based training and educational programs for medical students and professionals, which we're doing right here. So again, there's many tips. There's cultural competence, the idea of the context and the community that you're working in, and making sure that you're very aware of that as well. Oh, I think, here's the ROI. Yeah, I did put that slide in there. So again, it's a complex problem for which we have many effective tools. We know that for every dollar invested in universal implementation of prevention programs, we save $18. We know that our prescription drug monitoring program had a 36% decrease in doctor shopping. We know that, let's see if I can go back. Yes, treatment is about $7 to $12 return on your dollar investment. 227 kits, I didn't remember that exactly right, for one save. We also know, which one was that? Evidence-based drug courts, which we didn't talk a lot about. There are some drug courts. They are wildly variant. The way that folks approach drug courts varies across the nation, and most drug courts that I've come into contact with do not allow their clients or the folks in drug court to use medication-assisted treatment. They typically allow them only to participate in day reporting centers or day programs that are abstinence-based. So there's a lot of work to be done there. But there's a good return on investment with that. We know that $5 for every dollar invested in LARC, or voluntary reversible long-acting contraception. We know that for employers who use SBIRT or some referral and address mental health issues in the workforce, that they get $4 for every dollar invested in those training programs. This is one I can't get folks to buy into and to really get a whole lot of businesses to do this, but some are open and willing. And then prescribing guides. I don't really know what that slide means. I didn't make that one, but yes, your prescribing guidelines are available and accessible. So that's the content of the presentation, and I got done 15 minutes early, so I'm happy to answer any questions that you might have about the use of any of these interventions. For those of you that did the reading, any thoughts about some of the programs that they recommended implementing in clinical settings? I would like to hear a little bit more from you about how, is anyone an MD, MPH? No public health folks. So I'd be interested to know what your ideas and thoughts are about public health approaches and how you would integrate any of this into your clinical practice.
So I feel like here as a residency program and being in the epicenter, we are already
Mhm.
Certainly, I think it's nice to see what public health interventions are going on in our community to say, oh good, we're educating people on this, or there's a big push for naloxone in the community, it's not just coming from us. But as far as how this presentation would change our clinic practice, I don't think we're gonna open a Suboxone clinic. And I think a lot of us are already pretty on board with medication-assisted therapy as a community. So I'm glad you guys are working out there for the general public too.
Yeah. And I would be interested, so, you know, initially buprenorphine was not meant to be done in a separate setting. It was intended for primary care. So the whole purpose of this treatment was so that folks did not have to go to a separate building, that they would be in the room with like any other healthcare problem. But we're still sending them separately, and like you said, we're not going to be doing this here, probably.
We used to have one, and I think it was stopped for a reason.
Mm-hmm. So it's really interesting. So it sounds like you're feeling that folks are very open. When we poll folks across the region and say to primary care providers, how many of you would be willing to treat folks with substance use disorder in your primary care clinic? Overwhelmingly, most of them say we are not. And we get quotes like, these people, we don't want these people in our waiting rooms, it's too complicated. So I'm curious about, you know, how we can work together so that it's not like, this is what we're doing in the clinic, this is what public health is doing, we respect one another. But what's the overlap for all of us? How do we encourage medical professionals to join anti-drug coalitions? How do we encourage them to maybe, so I'm interested in your thoughts about that.
Well, I've been in private practice in South Carolina and then in faculty here. There's no question in private practice there's stigma in the waiting room.
I think we're wrong in calling it stigma. There is some fact to there's some fact attached to that stigma, and
There
we
is.
experience that here.
So give me some more information about that.
I mean, we had patients who were uncomfortable being in the waiting room, felt unsafe being in the waiting room, in the parking lot, with some of the people who were coming here for Suboxone therapy.
Mm.
And so, you know, if you're bringing your child for their well child check and somebody is selling their Suboxone in the parking lot, you don't want to come back.
Mm-hmm.
And so it's not just a stigma. There really are problems associated with that population
Mm-hmm.
that have to be addressed.
Mm-hmm.
So what I was saying is in private practice, there's really a disincentive to have that. I think in terms of trying to pioneer a public health, family medicine partnership, probably starting it in academic places is probably your best bet.
Mm-hmm.
Someplace like here. You know, in private practice, when I left, there were very few electronic medical records. There were no pharmacists working with film medicine teams. I mean, we're kind of cutting edge here, and something that we can make work here might then spread to private physicians. And I don't think it's going to happen the other way around,
Mm-hmm.
quite honestly.
Yeah, that's what we're finding as well. And I'm interested to know more about, so the Suboxone patients that you said were sort of making other people uncomfortable. How is that different than folks who were maybe drug seeking before? Are these a similar population for folks that would come in and have an ailment and be asking for scripts? Is this a similar population or a different population?
Our Suboxone clinic ran from about 2003 to 2009. We had 3 faculty here who were licensed to dispense buprenorphine. I was not one of them, but I was the only one left who's been there that whole time. We had a front office person who was very, very dedicated to this program, and she made sure that everybody was in the counseling and behavioral treatment with it, which was a requirement of our program. And our program also weaned people off of Suboxone over years. The reason we had to shut it down is there were many dock-in-a-box and fly-by-night people who were asking for $100 up front and then giving people whatever they wanted. And people no longer wanted to get off of their medicines. They wanted to either do maintenance or
So the decision to close it was more based on that than the
Yeah.
stigma? Okay. The business model.
Yeah, since then, all three of those faculty are gone, but
Okay.
that was not the reason we shut it down.
Okay. So that's what we're finding in at Overmountain Recovery is that in North Carolina you can get twice the dose that you can get here. And so our uptake of methadone has been slow, and our business model is more challenging than we expected because you can drive 1 hour away and get twice as much in the state of North Carolina.
I have a patient on methadone, stable, and I'm very happy for her. She actually still goes to North Carolina because it was so much cheaper for her to stay at her current clinic than go to the one that opened up locally because she had to start over kind of there instead of continuing her current therapy. So yeah, there is some disincentives for people to do it locally.
For sure, especially in the current environment with cash-based programs. Did you have something also?
You've obviously talked in the community a lot. Are you aware of any clinics that provide medication-assisted therapy that have pre-printed prescriptions with allergies to naloxone?
I've heard a lot about this. Yeah, because folks tend to, I think that we're doing a good job. I think a lot of those are closing down, I think with the new guidelines.
You have heard.
Oh, yeah.
Okay. I want to know if it was a true thing.
Well, there was a Tennessee law that took effect, I think it was August 1st of 2016, and half the pain clinics in town closed. Yeah, those were the shady ones, but still.
And so, we've had, Tennessee did a sort of a landscape of counties that have unmet need for medication-assisted treatment and those that have, did you see this maybe in an earlier version? So Washington County has this was a year ago, 2,000% capacity. So we had 2,000% more capacity than actual need for medication-assisted treatment. So you can see why our models aren't working, but now I think that would look very different. The new guidelines, I think, are really shifting that. So what are your thoughts about clinicians participating in things like anti-drug coalitions or other things that are public health, things that are happening in the community?
I think there'd be interest, but quite honestly, I'm stretched in so many directions, I couldn't do it.
Yeah, no time to do
I
that.
think private practice docs may even be worse.
Mm-hmm.
It's one of the reasons I went into academics.
Yeah. So are there other ways to integrate some of these preventive things like family checkup, triple P, some of the other interventions? Is there time to do that in a primary health care setting?
So I don't actually know what programs you're speaking of right now.
It was in the pre-reading. Yeah. That's okay if you weren't able to read it. But there are a number of things that are mentioned, ways to intervene. There's a 10-minute intervention on parenting, because often folks come into primary care where they're having these discipline problems or potty training problems, and there are interventions. Is there time for that in a primary care setting?
We utilize our behavioralist a lot for that in this clinic. So literally, I had somebody do a potty training intervention just the other day. So I think that we are kind of uniquely situated in that we have that support here, but we're not always doing it ourselves because of time crunch.
We make some time for projects, and that might be a way to break in terms of adding something to what people are already doing.
Right.
That's not going to work very well.
And so that's where I think sort of we've always kept sort of behavioral health care and sort of primary care as very separate entities. And I think now with the new model of chronic disease, it looks very different. And so how are we going to begin to sort of bring those together and provide the resources, not just in places like this that have all of these extra resources, but sort of how are we going to start bringing all of that together in other areas, especially in rural areas. So it's a complicated and challenging problem. So any other questions that you have from the previous model, anything that I can be helpful with, or resources?
I'm not really sure how we can make the first move for getting some cross-pollination here, but clearly it's happening.
I think our clinic would feel it's not exactly in the way we're talking about, but the injectable naloxone treatments for people that are already off. I think that would be something we might be more comfortable with here as a starting point anyway.
Naltrexone.
the deep pushback.
We're already dealing with it.
Exactly, like I had someone come to me, so I think like, those are like little baby steps in that direction, you know, we're trying to.
Yeah. And I'm still interested, and we're talking about business model versus discomfort in treatment. And so I think that sort of, there's a lot of conversation probably to be had if we're talking about treatment, which is different than sort of integrating prevention.
I'm not on the business side of things, but it is my opinion that the business model was used as an excuse to finally get rid of the Suboxone clinic because of the other complaints. That's just my opinion.
Yeah. And naltrexone, I think, is a great resource for folks that have been abstinent for 7 days. I think they need 7 days of abstinence. And it's also great for incarcerated populations. Right now, it's so expensive. So I don't know how to get it covered.
Insurance covering some of the ones that we have on it?
Both of the patients that we have.
Oh, great. You have two?
Yeah, we have
That's
two.
awesome.
So,
So they have their own private insurance.
yes.
Yeah.
And pick it up. The one person does, and the other one has Medicare.
There you go.
So,
You guys take care of Medicare on it.
yeah.
Okay.
So
Great.
They picked it up at the pharmacy and bring it with them. One of them does, and then the other one, their pharmacy, mail order pharmacy, delivers it directly to the office and we schedule injections.
Awesome.
So,
That's good to hear. Yeah, so that's, I think there's some movement there at TennCare level. Okay. Well, unless you have any more questions from me, I hope it's okay that we're finishing early. Okay. Yeah, thank you.
Thank you.